Welcome to the SCR Connections webinar. Thank you everyone for joining us. It is my pleasure to introduce our guest speakers, Dr. May Lau and Patti Pagels. Dr. Lau is an assistant professor in the Department of Pediatrics at the University of Texas Southwestern Medical Center and the medical director of the Adolescent and Young Adult Clinic at Children's Medical Center in Dallas. As one of the few board-certified adolescent medicine physicians in the Dallas area, Dr. Lau has been recognized as one of the top adolescent medicine specialists by D Magazine since 2011. She provides care for transgender youth in the AYA clinic and the Gender Education and Care Interdisciplinary Support Program. Her work has appeared in the Journal of Adolescent Research, American Journal of Men's Health, Vaccine, Journal of Pediatric and Adolescent Gynecology, and Maternal and Child Health Journal. I could say much, much more, but I encourage you to check out her bio on our SCR Connections webpage. Patti Pagels is an associate professor in the Department of Family and Community Medicine. She is responsible for mentoring family medicine residents and scheduling them to partake in service learning experiences. In the second role as medical director for a homeless shelter, Professor Pagels supervises clinic care and teaches students and residents to practice care oriented towards health promotion and disease prevention. Third, on a volunteer basis, she provides direct patient care, clinical oversight, and access to hormone therapy to transgender patients at a community partner, the Dallas Resource Center. Again, if you want to learn more about her, her full bio is on our website. I'm now going to go ahead and pass the ball over to our speakers and let them get started. Good morning, everybody.
Good morning. This is Patti Pagels. I'm going to go through the slides here. Is that not moving forward? Thank you for joining us. And these are the objectives that we're going to try to cover. Our plan is to go through the slides for about 45 minutes and then leave some time for questions and discussion. So first of all, I think it would be valuable to go over some of the terminology so as we go along that we're all on the same page. So cisgender is an important term because that is sex assigned at birth. It corresponds with your gender identity. So transgender is somebody that has a sex assigned at birth, but the way they feel and identify is quite different. And so you have affirmed female or male, their preferred terms, or female to male or male to female, less common, but sometimes abbreviated and used often in medical charts because it's just shorter. And then there's gender expansive and gender nonconforming. So these are people that don't really fit into either of those categories. They're somewhat fluid in who they feel they are, and they fall outside of what we call the traditional categories of man or woman. And that's not all that uncommon to find that in this population of people. Up here.
Okay, and this is May Lau, and so the latest data shows that the number of transgender individuals in the United States is about 1.4 million. And it's really hard to get a good number because we've just started asking this question on different surveys. So in Texas, I have data for Texas. I looked for the other states, but I couldn't find them. But for Texas, there's approximately 125,000 transgender people. And in the U.S., there's about 150,000 youth in the U.S. who identify as transgender. And so when we look at transgender youth and mental health, we can see from this a May 2019 study of transgender youth from 3 to 17 years old, common diagnoses for 3 to 9-year-olds compared with their peers. And they have greater prevalence of ADHD, anxiety disorders, conduct disorders in affirmed females, and depressive disorders in affirmed males. And then when we look at older youth, we can see that the more common diagnoses for 10 to 17 years old are depression, ADHD, and anxiety, and suicide and non-suicidal self-injury. They also noted a higher prevalence of autism diagnoses in affirmed females and schizophrenia diagnoses in affirmed females. And a point to make regarding the suicide and non-suicidal self-injury, it hasn't just been this one study that has documented this, but several studies have documented that transgender youth have higher rates of suicide and suicidal ideation. There was another study that looked at, when they compared transgender individuals, that transgender females, or affirmed females, are more likely to commit suicide compared with transgender males.
I might just add, this is Patti, I take care of adults, while Dr. Lau takes care of adolescents, and this is not so different. The depression and anxiety are very prevalent, and it persists into adulthood, particularly if they have not received treatment earlier in life.
And then we now look at substance use in adolescents, and they used the Youth Risk Behavior Survey, which looked at 9 to 12th graders, and they looked at 10 states and 9 large urban school districts, and they noted a greater prevalence of ever using any substance compared with cisgender peers, and that includes cigarettes, alcohol, cocaine. And now I want to spend a little time talking about sexual orientation and gender identity. Much of the literature combines sexual orientation and gender identity, and it's actually separate. So identity is how you see yourself as. Your gender expression is the type of clothes, the hairstyle you may have, the mannerisms, the demeanor, and the sex is the biological sex is what is, you can say colloquially, what is between the legs. And your gender does not equal your sexual orientation or who you're attracted to, because, gender is how you see yourself as, and attraction is who you are sexually attracted to.
Yeah, you'll see this quite often where somebody will identify as female. Their gender at birth is male, but they'll identify as female, but their partners may be males. So you have to really explore this when you are talking to a person that is transgender, because who their partners are can be very different than what you think.
And it's true, I just want to go on that. You can't, as you mentioned, you can't assume. So it's very important to ask open-ended questions in regard to who they're attracted to. And sometimes you may need to ask, if their partner is cis or trans, so you can determine their risk for sexually transmitted infection.
Yes. And then the question that comes up all the time is, well, why does this happen? We don't really understand it very well. I think that now with some new genetic studies and chromosomes, there may be some genetic variation that may play a role. There may have something to do with childhood psychology factors, perhaps, although that is not the most common reason. You can find the person with the most ideal childhood may still identify as transgender. Anatomic differences may result from brain structure or activation from particular hormones in utero that may cause people to have gender dysphoria or have different gender identity than their sexual parts. So we really can't say definitively what the reasons or causes are.
And so there are actual clinical practice guidelines that have been developed. Now, the World Professional Association for Transgender Health, or WPATH, published its latest version in September 2011, and they're currently working on a different version of the guidelines. And the Pediatric Endocrine Society, or PAS, these guidelines, the most recent guidelines were published in November 2017. And there are other additional guidelines, the UCSF guidelines or another set of guidelines that provide guidance to clinicians who are taking care of transgender individuals. So this is the diagnostic criteria used by the Diagnosis and Statistical Manual of Mental Disorders, and this is the 5th version, and it says, it defines what gender dysphoria is, and the time that's needed for diagnosis is at least 6 months. So for a mental health professional who is using this, they need to meet certain criteria, and I can read this to you. So it's really a marked incongruence between one's experienced and expressed gender and assigned gender, plus at least one of the following. So they need to have a desire to be or an insistence that one is the other gender, preferences in clothing and attire, roles in make-believe and fantasy play, toys, games, or activities, and playmates of the other gender, dislike of one's sexual anatomy, and desire for sexual characteristics that match with one's experienced gender. And you will have children, 3 or 4 years old who, may not be express themselves very well, but they can say, even though their biological sex is a boy, they say, I am a girl, and they will refuse to wear, boys' clothing and only want to wear girls' clothing. And so some of the recommendations are, especially when it comes to evaluating of youth, is that only mental health professionals, abbreviated as MHPs, who fulfill certain criteria should diagnose gender dysphoria, abbreviated here as GD, or gender incongruence, GI, in children and adolescents. And so they need to have knowledge about the diagnostic criteria that I just mentioned, to have sufficient training and experience in assessing the mental health conditions, and to be able to participate and willing to participate in the care during the entire transition process. These mental health professionals also need to have training in developmental psychology and psychopathology. They need competence or have competence in using the Diagnostic and Statistical Manual of Mental Disorders, the DSM, and or this other one called the International Classifications of Diseases, the ICD, for diagnostic purposes. And they should be able to distinguish between gender dysphoria and gender incongruence in conditions with similar features, such as body dysmorphic disorder, or this body integrity disorder, or a form of eunuchism, which with castration is not related to this, a gender. And they actually need training in diagnosing psychiatric conditions. So these mental health professionals also need to have the ability to undertake or refer for appropriate treatment, to psychosocially assess the use, understanding, and conditions that can impact gender-affirming hormone treatment. So they need to understand, how different things work that can affect their treatment. These mental health professionals should regularly attend relevant professional meetings, and they need to have knowledge of puberty blocking and gender-affirming hormone treatment criteria.
So let's now talk a little bit about barriers to care. There's been numerous studies. We even do surveys with the adult patients in this community clinic here in Dallas. But this is a big problem. People that identify as transgender, and I'm talking now primarily about adults, have comfort with the primary care physician that's associated with better mental health. So when they have somebody that they trust and they can go to for general health needs, they're better adjusted. Over half of them have not had the needed care. They'll avoid going to the emergency room. They may not identify that they are trans persons. And then there's a cost. A lot of these folks are, if you look at social determinants of health, they're underemployed or not employed or only employed part-time. They've all talk about negative experiences with healthcare providers, and then the concern of being judged by the healthcare clinician that they're seeing. Many of them have had some very significant negative experiences that keeps them from getting the care they need. So there's not a lot of pediatric providers trained in gender-affirming care. I think that's why the program here between UT Southwestern and Children's Medical Center in Dallas is so important to find these children early. It's very hard at the adult level to try to undo a lot of the wrongs or to, you know, get people to look feminine or masculine once they have gone through puberty. It's important when you're talking with individuals that are affirmed female or male to use a consistent pronoun, the he or the she. You know, they need better access to care, less uncoordinated care. There's lots of needs that they have that, you know, sometimes not taken on very well by the primary care office. And then limited delay to access to blockers and cross hormones means that some of these characteristics later on, even despite testosterone or estrogen or testosterone blockers, you know, it's very hard to make somebody look very feminine. It's easier to make them look male. And then now, you know, we have so many insurance exclusions. Many people take jobs that they don't particularly want, but in fields where the insurance is very good and will cover some of these surgeries that masculinize or feminize them. And in one study, it showed that only half of primary care providers, that's internal medicine and family medicine, were willing to provide cross-sex hormone therapy. So that's a real problem.
So I want to touch based on something that a lot of transgender youth and adults are concerned that they actually have to educate their providers on how to care for them. And so that just makes it really difficult. And I think that, you know, we talk about the lack of pediatric providers. When I was in training, this was not part of my training. And this is something I decided to undertake and care for these marginalized youth. So I made the effort to study this. Now, healthcare professionals are now being educated more on caring for transgender individuals. And we're actually conducting a study here looking at different healthcare professionals and what they desire, what they need in education on transgender health.
Yeah, I certainly didn't get any training as a PA. I just heard that this community organization had over 100 people on a waiting list, and people were waiting for 12 months to get hormone therapy, and they started coming from 200 and 300 miles away, coming from Arkansas, coming from Oklahoma. So there is a definite need for clinicians to train themselves.
And so speaking to what Patti said, for me, I actually got a call from a pediatrician who, and they were about maybe 2 hours away from Dallas, and they had someone who was transgender and needed care, and they didn't know what to do. And they thought, like, let me call the adolescent clinic. And I at that time, did not have any training. I said, send them my way, and we'll take care of them. And that's how my road started.
So the barriers to care model, or the standard model, is that people seeking gender-affirming treatment should have a mental health evaluation, because we spoke earlier about how many people have depression, anxiety, substance abuse disorder, suicidal ideation or thoughts of that. So that is a very helpful thing to get, particularly with adolescents. In my adult practice, I don't always require this. I mean, some people have been thinking about it for years. They've looked it up. They know a lot about it. They've been to groups with other transgendered individuals, so they're pretty clear about what they want, but it is recommended. Referral letters then can come from that mental health evaluation. Then the consent model, which is more what I use with adults compared to Dr. Lau, is I help them make the decision. I review risks and benefits of hormone therapy, not only on their physical appearance, but on their mood and the way they feel about themselves. And then if they have some other mental health issue, I may ask that they get that assessed or be a part of what we're going to provide for them.
So many of the youth that we see in our Genesis clinic, our multidisciplinary gender affirming care clinic, are adolescents. And it's really important that adolescents have time alone with their providers, whether it's a primary care provider or a subspecialist, because they will not be honest with the provider or with anyone if they feel like their parents may find out certain information. And there's certain aspects and certain conditions that adolescents can get confidential care for, but again, it's really important that adolescents have time with their provider and that they are not feeling rushed, because if they feel rushed, even though they have time, they're not going to want to discuss things that are on their mind. And again, it's also important to ask open-ended questions regarding what they might be feeling or the concern they might have, so that it's telling them that you want to have a conversation with them. And so, we've tailored our electronic medical records to adjust for transgender youth. So we have a legal name versus a preferred name. And as you can see over here it might be to your right, the legal name was Chantel, and then for this person, their preferred name was Dexter, and that's what they prefer to be called. Now, I will tell you that sometimes the preferred name could change. And so for this individual, they actually went through they started off with Dexter, they went to Zolani, then they went to Hugh, and then they went back to Dexter. So it's important to ask every visit what their preferred name is. And then you have the preferred pronouns. And these are some examples of what they use. And, for me, when I go see a patient, sometimes I have to think in my mind, I'll say the pronoun in my head, she, or he, to get me into the right frame of mind so I don't accidentally use the wrong pronoun. If that does occur, I just apologize and I state I don't mean to be disrespectful, and then I move forward. Now, for those who are non-binary, they may choose to use the they, them, theirs pronoun. And, as a clinician, that's a little harder to get your mouth around because it's such a mouthful. But, again, that's an option that we ask them. And, again, sometimes youth will change their preferred pronouns. They'll tell you it's they, them, theirs, and then the next time you talk to them and you ask them what their preferred pronouns, they say, you know what, my preferred pronouns are now she, her, and hers.
Yeah, that's fairly typical. That kind of persists into adulthood, too. Yeah, and it was uncomfortable for me to say, do they want their blood drawn? It takes a little bit of practice. The she, he is a little easier, but as you do it more and more, it becomes natural.
And so this picture is just to show you how all the different terms that can be used in regard to gender. Bigender might be someone that's identifying as two genders, or a demi-guy is someone who is identifying partially as a guy but not totally as a guy. And so when someone uses a term with me, I will ask them, what does that mean to you? Because I know what it means to me, but you may use it differently.
Yeah, yes, and you have to ask them to define who they are. These are just some words, and they're helpful, but when you're engaged with a patient, you ask them to tell you. I don't listen to them and then come up with a name. I want to hear what they call themselves. I think that's more important. So sexual orientation, being asexual is not being attracted to anyone. And you do see that in adult affirmed male and female oftentimes. They become kind of isolated. They're fearful to go out. They don't know how they'll be perceived, so they become somewhat asexual. Demi, it means attracted to someone after developing a strong bond. Hetero, I think we know. Homo, we've all heard that. Bi is somebody attracted to both genders other than their own. And then pan is somebody that, kind of open to anybody. And poly, attracted towards multiple genders. So that would be male, female, bisexual, the pansexual. It does get a little bit cumbersome when you think of all this, but this is where you have to, as clinicians, you have to talk to your patient and ask them how they identify, what are their behaviors and so forth. And so anatomical terms that come up, instead of, it's kinder to say chest rather than breasts. Instead of using it's more like kind of, I think, going back to childhood, the private parts or the external pelvic area, because if you desperately want to be a male and you're a female, you don't want to think about your breasts. You want to talk about your chest. So you don't want to hear those words that describe your gender at birth. So that's why we've come up with less gendered terms to be kinder with the patient.
And so I figured it might be helpful to talk about a few cases. So, we have a 12-year-old female who identifies as male and is currently using the given name and wants to use male pronouns and name. And so K, that's the preferred name, his parents and healthcare team agreed that he has gender dysphoria, that his identity as male is stable, and that he would like to transition to male. So the first step in transitioning someone at 12 may be just doing reversible steps, such as changing your clothes, your hair, your shoes, the toys, and possibly starting GnRH agonists. And so this prevents the hormones of puberty from causing developmental changes. So if someone was started on this early on, say when they started puberty, they would have a better outcome than someone who has gone through puberty but maybe not be of the age or may not be ready to start cross-sex hormones and is starting on a GnRH agonist. And
then the hormones are reversible, are most partially reversible, and we're talking about adolescents here primarily, but it's true for adults too. And then, of course, if you go through gender-affirming surgery, then that is irreversible. You can't go back to that, so you can imagine that's a big step to take with someone.
And so, if they're going to start with puberty suppression, the recommendations are that they meet that criteria for gender dysphoria and gender incongruence, which these two terms are interchangeable. So dysphoria and gender dysphoric and sometimes known as gender incongruence, that they fulfill the treatment criteria and that they request treatment that begins with puberty suppression. And that pubertal suppression therapy begins with the onset of physical changes of puberty. And so you don't really need to confirm puberty by checking labs. This is something that can be done clinically by a physical exam. And so the pros and cons of this is that, one of the cons is that, adolescents' gender identity is fluid. So from one day or one point in time, they may say, no, I'm this, I'm female, but then they realize later on that I'm male, and that we're not sure about the safety and long-term effects of puberty suppression in youth with gender dysphoria. We do know that this is safe to use in youth with central precocious puberty, but we don't know if we can translate those side effects and the long-term effects to those with gender dysphoria and who are using puberty suppression for those reasons. Now, the pros are poor psychological health if denied treatment. So by doing this initial step, this may help their psychological health. It actually increases the duration of the diagnostic phase so that if there is some questioning about the persistence of the gender dysphoria, we have time, and that gives the adolescents time to realize that no further changes can occur, and they can, work with their therapist, discussing their concerns, and that this in time will lead to their physical appearance equaling their desired gender. The second case we have is B, who is a 16-year-old affirmed female. So this is someone who has gone through male puberty and has never received puberty blockers, and she wants to start estrogen. So how do we medically support her transition? So this is partially reversible. So the hormones that are used in the masculinizing and feminizing hormones are partially reversible. Some of the consequences of the hormone therapy are permanent, but most of them will go away once the therapy is stopped. And so, you know, when they start cross-sex hormone therapy, the youth can transition to a physical state that more closely represents an individual sense of self. And this helps with avoiding depression and risk-taking behaviors that we mentioned in the earlier part of the presentation. It establishes an early, strong support for the gender, and they can experience the puberty that's congruent with how they see themselves, and in a way can prevent unwanted secondary sex characteristics.
So some of the effects of the feminizing hormones, this is the estrogen, is they get some reversible, a redistribution of body fat. So you'll see more in the hip and the buttocks and less up in the arms. The muscle mass decreases, skin is softer. They get some decreased libido and erections, and in adults this becomes an issue and sometimes has to be treated depending on who their partner is or how they're performing sex with that partner. If they get breast growth, it's not reversible, so some of that will stay. Then the testicular volume decreases, and probably that is not reversible. So those are important things to point out. And then, of course, the sperm production is decreased in terminal hair growth. But those are reversible once they stop the feminizing hormone. And this is estrogen we're talking about. And then masculine hormones, this is a much more powerful hormone. This is testosterone. This is the androgenic kind that brings on the acne, more facial hair. Oftentimes in 2 or 3 months I see in the adults that they already have some facial hair, and that's very confirming for them. They may have some of the male pattern baldness. They get muscle mass. If they start to go to the gym, they look very masculine. Fat redistributes. Sometimes it'll take up to, I've seen it sometimes take at least 3 months to stop the menses. Sometimes it'll happen in the first cycle. If the clitoris enlarges, you won't see that return to normal once they stop. They will get some atrophy of the vagina, so that can be important to discuss with the patient because they'll need some sort of a water-based lubricant if they're going to still use the vagina as part of their sexual pleasure, and then a deepening of the voice, which may not change. You know, I've told Dr. Lau several times, you know, why I think it's so important that these folks get identified in childhood is because when they come to me and are 30 or 40 years old and they've been under the influence of their gender hormones all this time, it's very hard to reverse it. I can't take somebody that's, you know, 5'10" and very muscular and make them a woman overnight, even if they use the clothing and so forth. So I think that's kind of important to recognize that.
I think it's important to stress that what Patti mentioned about how testosterone is a powerful hormone. So I tell them that the effect of estrogen is like a feather, you know, it's just a whiff. And whereas testosterone, you give it a little bit, you get a lot of an effect. So for some of our transgender females or affirmed females, we will use puberty suppression medications to suppress the hormones of puberty, so that means testosterone is decreased, and then supplement with estrogen therapy so that the estrogen can have an effect on their body.
Well, one thing that comes up is fertility issues. If you're going to be on suppressive hormones of either kind, you're going to have decreased fertility, and that's something that has to be discussed. I mean, even transgendered individuals sometimes want children. They want the typical, you know, family and the typical relationship. So you have to talk about the egg banking or embryo freezing or sperm banking. and these things are not cheap. They're not available in all locations. For females, it means a surgery to extract that egg and keep it somewhere. So it's very important to have that discussion. Many times the people that I see are kind of past the point of wanting to have a family, or they've talked about getting adopting or getting a surrogate. But it does have to be discussed, and it's not something cheap.
And, you know, for our adolescents, many of them are not even thinking about being parents. And when they do sperm banking, sometimes it's for the parent's desire to make, you know, they don't want their child to have any regrets that they are unable to have biological children. You know, some of our patients who have gone through sperm banking or attempt to get a sample actually don't have any sperm. From when they look underneath the microscope, there is no sperm, even though they've gone through that process. And for those who have started puberty suppression medications, when puberty starts, they would actually have to go through stop their puberty suppression medications to actually have significant pubertal maturation in order to have enough material to cryopreserve. So I will point out that when I do counseling with the families for our affirmed males, I let them know there is a case series of affirmed males, adults, who decided to get off of testosterone, and they became pregnant. They had a healthy pregnancy and a healthy baby, and so that it is possible.
So case 3, or T, he's a 17-year-old male. He wants breast surgery and hysterectomy. So those things, of course, are not going to be reversible. Not all people select these things. What I see most often in adults is it's kind of they want from the top up to look the gender they identify with, and most of them don't go much further than that. Sometimes it's fear, sometimes it's money, but it is irreversible.
And this shows that the number of gender here, from this slide, it says gender reassignment surgeries, and they don't use that term anymore. But I want you to look at the graphic to see that the number of surgeries have increased and continue to increase. And many of our patients, between the both of us, are getting them done. Then there are more surgeries for the affirmed females than the affirmed males.
And we may not know how many people actually are getting gender-affirming surgery, because some of them are going to Thailand, they're going to Europe, they're going to other countries to get this done because it's much cheaper. So what do you need to do to have gender-affirming surgery? Well, you have to have persistent and well-documented dysphoria, gender dysphoria. You have to, of course, be old enough to consent to surgery. You have to have been at least 12 months living as the gender that you want to become, and you do it consistently and responsibly, and then successful and continuous full-time living in a new gender role. And then if there's significant medical or mental health concerns present, they have to be well controlled. So it doesn't mean, well, just because you have depression, oh, you can't have this surgery. Well, yes, you most certainly can. If, you know, there's other causes of depression that may have nothing to do with their gender identity. And then they need to know that all of the practical aspects, they kind of need to be able to recite what's going to happen. Some things don't always work the way people anticipate them working, so they need to know all that, like any person getting surgery. So if people are very satisfied with the hormone effects, that might be a person that you can refer for gender-affirming surgery. They want the surgical changes. So in youth, it might be, you want to talk about the youth?
Yes, so there's a recent study, May 2018, that suggests the timing of top surgery or breast surgery for affirmed males should be based on physical and mental health status as a youth, not by a specific age. And I will tell you that we have had youth in our clinic come in who have had top surgery before they even started hormone treatment.
So what are some of the other options for affirmed females? And you can see this dramatic change in this individual here. So breast implants, having orchiectomy or penectomy, meaning taking out the testicles and the penis, vaginoplasty, creating the neovagina. But many people first start with the facial feminizing surgery to shave down the jawbone, sort of a change in the forehead takes place, vocal cord surgery so the voice is congruent with their gender, tracheal shaving. There are plastic surgery with implants for hip and buttocks to make them look more pronounced. For the waist, even some people go as far as a rib removal. I have not encountered anybody gone that far, but those are some of the things that can be done to feminize. And then for males, it's the chest construction, mastectomy, or implants, and then the taking out the uterus and the ovaries, creating the new penis, which has no function. They have to have a pump to make it function, and it's rarely covered by health insurance. So it's quite a journey for people, and it's very costly. And then I think we have this slide because we mainly are talking to people in Texas, but I'm sure in some of the states that you are in that there's lots of legislation being proposed about the LGBTQ community, about what their rights are, their right to work, or, can they be denied services? Can people in the health professions deny to take care of them? What bathroom are they going to use? I mean, we can go on and on. I think you probably monitor some of this yourself or you see it in the news, but I think it's important to be aware of how this really affects the transgender community. It makes them very fearful. It really isolates them. They don't feel like they're a part of society. I think this issue with the bathroom is a really big deal because if you're dressing like a female and everything about you is feminine and you go into an all-men's bathroom, I don't think it's safe for you in there. I think something bad will happen to you, and they know this. So I think it really creates this lifestyle where people don't go anywhere because they don't know, even online, who they're chatting with. Are they going to meet up with somebody and then have something bad done to them? I mean, we've had several trans females killed here in Dallas in the last year, 3 of them, in fact. And so I talk to my patients, and a lot of them say, oh, don't worry, I don't go out. I'm too afraid. There's some resource locators, and I think those will be posted on the slides, and here are some references. And I think at this point we'd be happy to take some questions or comments from the audience.
Great, thank you for that. Yeah, hello. Thank you for that presentation. Very insightful. I'm just going to start at the top. So there are a couple questions that came in about defining an affirmed male or female, please. Someone said that affirmed male-female is not used in the queer community in my area, but from what I understand, affirmed female equals trans woman, affirmed male is a trans man. Perhaps the host could confirm.
That is true, and I think it differs for in different communities. I was using trans male and trans female, and someone came up to me and said, "Hey, we don't use those terms in this community here in Dallas. We're using affirmed." I said, "Okay." So and you can always check with your patient how they would want to be referenced, but honestly, they want to be referenced by their preferred name, or if they've legally changed it, their legal name.
Great. Next question. Dr. Lau, why would someone's partner's status as cis or trans influence one's risk for STIs?
So, when we ask who they like, who they, want to date, who they like, they may say male, female. They may not, our adolescents are very concrete. Many of them are very concrete, and they're not very abstract thinking. And it does make a difference because it can put them at increased risk for infections and or pregnancy, which we didn't touch on. So if you have an affirmed male who still has a vagina and a uterus and is having sex with a cis male, they are at risk for pregnancy and sexually transmitted infections. And so that's why we ask, so we know how we should screen someone for sexually transmitted infections or pregnancy.
Great.
Yes, it's very important to have a very honest discussion with the patient, because where you take a culture from, or to look for gonorrhea or chlamydia in particular, you need to know what orifice is being used. Is it rectal? Is it vaginal? Are they using the penis? Is it the mouth? Where is that going to come from? Otherwise, you're going to miss a lot of these STIs or sexually transmitted infections.
Okay, I believe you talked about this earlier, but one of the questions that came in is, could you explain the difference between GD and GI? I believe you did say it was interchangeable, but are there any distinctions that people have made between the two?
Not that I'm aware of, but that, depending on the terms that are used by the mental health professional, they may, gender dysphoria is what we commonly use, but there might be some people who use that term gender incongruent, so that people are aware that they be synonymous.
Some patients don't like the word gender dysphoria either. That's another thing. They feel that they're not dysphoric, that there was a mistake made, and they should have been a male or a female, and that's not their problem. The problem exists somewhere else. So some of it you really have to talk to the patient. You really have to have very honest discussions about what word should I use, how should I refer to you, but some of them are very adamant about what you need to be calling certain things.
Great, thank you. Again, if you have any questions or comments, please put them into the chat box. There are a few more. I'm going to continue. Someone says, I just want to comment that asexuality is not synonymous with being afraid of connection. There is a distinction between asexual and aromantic, and both types of people can and do enjoy close, intimate relationships.
Yes, thank you for correcting me. But when I do talk to some of the patients, I find that I'll ask them, why aren't you having any connections with people? Well, I'm just really afraid. I don't want to get out there in the world and be let down or something like that. So, but thank you for making that distinction, because that was not accurate. Yeah.
Okay. Let's see. Another comment that was made. Please be careful when saying someone is a girl and wants to be a boy. It's not who they want to be, but identify as. Thanks.
Thank you for the comment.
Another commenter said, also, nobody can make a male identified at birth into a woman overnight. I'm going to go ahead and insert my own question for you all. I know that many of the people who are attending today, they definitely refer members of the community to different resources. My question for you is, what resources have you found helpful for referring your patients to?
So I am blessed to work in a multidisciplinary program. And our social worker has identified many places for our youth to connect with. There's one that we have in our area called the Resource Center, where they have youth support groups and youth nights so that people can feel very comfortable. We also even sponsor, our clinic sponsors an event, or a yearly event. Maybe we're trying to make it twice-a-year event for all our patients so they can connect with each other, because as Patti mentioned, sometimes a lot of these individuals are kind of in a silo. They're afraid to connect with people, or they only talk to one person, or I have patients whose only friend is an online friend and they've never met in person. So but there are a lot of organizations in our area that we connect our patients to. Are you looking more for something, a national organization? Because I think I know you have people who are listening from very different states, then there are, they may have local organizations that can provide great support for transgender individuals.
I think that's where perhaps, the audience, or at least the librarians for their area, can build resource lists for people. I think a lot of people don't know how to use the internet correctly for appropriate health information. They read a lot of things that aren't accurate, are not scientifically based. So I think helping guide people on how to use the internet to find reliable information, or groups in the area that they can check in with or attend.
And I think our previous slide, right, so HRC is great, the Gender Affinity Resource Locator. So these are a couple of them, but there's always more. And I know I'll be speaking at the HRC annual meeting in DC next month. So.
Great, thank you for that. We have just 2 more questions here, and then we'll wrap up. Okay, so one is regarding the map on slide 4. I can understand why Georgia and California would have a high percentage of transgender people, but can you explain New Mexico and Hawaii?
I cannot. I'm actually surprised that Texas has so many transgender individuals too, if you look on that actual map.
Yeah, it's hard to determine why that might be. Yeah, we can't answer that. So if somebody has an answer, we'd like to hear it.
And I think research, in this area is just starting. So, we may find something out about this in the next couple of years. I mean, there's a lot of research. This is a huge area of research right now regarding transgender adults, transgender youth, and we may, find out a reason. Who knows, in a couple of years.
A comment in response to what you said. I tell residents at my hospital that if I ever catch them using Wikipedia for patient care, I'll take their badge away from them. The internet is not a reliable source unless you weed carefully.
So true, so true.
Well, that's where I think a librarian can be very helpful and helping guide them to reputable sites. There are places to go for information, but not Wikipedia. But this is where I think, I really can't say enough about the role that librarians can play, not only for learners, but persons, wanting to be more gender affirmed. Where can they go to get reliable information? So that should really be a safe place for people.
Another question, and I'm not sure if any clarification is needed here from the person who asked. Any studies or comments on long-term psychosocial issues on thriving?
So I'm wondering if you're talking about people who have transitioned and how well they're doing. And there are some long-term studies. I think the Dutch have them. I don't know if we have any in the United States, but I believe the Dutch, people do well when they are living as their affirmed gender. So I think they do thrive and they do well long-term psychosocially.
Yeah, I had a patient recently go to the Netherlands or Belgium. I can't remember where. They had a big pride parade, and they said that children were out, all ages, all kinds of people, and it was so affirming for this person that they finally felt like they were in an environment where everyone appreciated who they were and had no questions about why they were the person they were. And it was a delightful experience for them that they had never experienced in the United States, even at pride parades. So I think that's just the anecdotal thing to what you said, Dr. Lau.
Great. Well, that's all our time. So thank you again for both of you for speaking. It's been great. It's been a pleasure having you with us.
Well, thank you for having us.
Thank you for inviting us.